O'clock on the dot. We're going to go ahead and begin our program tonight. If you can all just please remember to mute yourselves, and we'll be moving forward. So good evening and welcome to SSM Health Cardinal Glennon Children's Hospital event, Accessing Care During a Pandemic, Back to School Edition. My name is Michelle Romano, and I'm the Vice President of Nursing, Chief Nursing Officer here at Cardinal Glennon, and I'll also be your moderator for our program. We're happy to have you here tonight with us for our panel discussion. During the next hour, our panel of experts will be answering your questions regarding care for your child during a pandemic. We'll first introduce you to our panel of experts and then open the chat room to answer your questions. Please remember to submit your questions via the chat box, and I'll read the question out loud and one of our experts will answer. For tonight's panel, we have with us Dr. Maria Strand, Dr. Aaron Miller, and Dr. Ken Haller. Dr. Strand, would you like to introduce yourself?
Certainly, have to make sure I'm not muted. My name is Maria Strand, and I am a pediatrician, a neonatologist for a specialty, and I am the interim chief medical officer for Cardinal Glennon. It is a pleasure to be here with you this evening. Dr. Miller?
My name is Aaron Miller. I'm one of the pediatric infectious disease specialists at Cardinal Glennon. And I'm also involved with infection control and antibiotic management at the hospital.
Hi, I'm Ken Haller. I am a primary care pediatrician. I've been at Cardinal Glennon for about 22 years now, and I see kids from birth to whenever they decide to leave in all configurations. And I work just like Dr. Miller and Dr. Strand. We work with medical students and residents, teaching them the art of pediatrics. And I'm also the immediate past president of the state chapter of the American Academy of Pediatrics.
Thank you all. And if you would like to submit your questions, please do that via the chat room, and we'll go ahead and start answering those questions.
One thing also, Michelle, I'd also be interested if people could just enter 1 or 2 words in the chat box about who they are. Are you a physician, a nurse, an educator, a parent? Just to get an idea of who our audience is. I think that would be really interesting.
Agreed, that would be great. I think as we're waiting for questions to come in, I just want to bring up the idea that there are lots of questions circulating right now about school and return to school, and what does COVID do when we return to school? How does that impact our families and all of that? And so I can just give a little bit of background to get us started on COVID in the younger age population, kind of what we're seeing from a regional standpoint, what we're expecting from a symptomatic standpoint for these kids, and kind of what parents are generally looking for. I think it's been made pretty well known that kids, by and large, have been sheltered from the really bad outcomes of this virus. It's been in the news that the people who have been suffering the greatest morbidity and mortality, the worst outcomes of COVID-19, are those that are older, so in the senior population, and particularly those that have multiple medical problems. So people who have diabetes or hypertension or morbid obesity are those folks, or other pulmonary problems are those folks who are really having trouble getting through the COVID disease. Usually, it's the extremes of age that have issues with infectious diseases. And so COVID-19 is really unusual that it's not impacting kids like it's impacting adults. What we have seen is that most of the kids who get COVID-19, or at least the kids who swab positive for COVID-19, the majority of them are asymptomatic. So they just carry the disease. And what we've also seen is that this youngest kids, those less than 10, and particularly toddlers who might be swabbing positive for COVID-19, don't do a great job of transmitting it to others. There certainly are cases where little kids will transmit the disease to other family members or other friends and things like that. But that's much less common than what we see with other diseases like RSV, during the winter cold and flu seasons. What's been interesting is that the kids who are 10 to 19 or 10 to 20, those are the kids who in the last few weeks have been getting tested more often and are coming back positive more often than what we saw earlier in this pandemic. And there's a lot of concern amongst the medical community at this point that it's those kids, those teenagers that are going out and not practicing the social distancing and not wearing masks like we would hope that they would, that are actually transmitting the disease at a higher rate than any other age group right now. So for me, as a parent of essentially 4 teenagers, you know, that gives me a lot of pause about sending them back to school if they're not doing a good job of socially distancing and wearing their masks. Those are the people that I think we're worried about at this point being more vectors. We certainly have seen kids who have had significant disease with COVID-19, but they've been a much smaller percentage than the adults that we've seen who have been suffering with COVID-19. So that's just a little bit of a snapshot of kids and teens in the region right now when it comes to COVID testing and positivity and symptomatology.
Thank you, Dr. Strand.
Of course.
We did have some questions that were submitted prior to tonight's event, so I will start with those. And as we see the other questions roll through, we'll ask those as well. So the first question is, with schools and colleges going back in session, what precautions should parents take to keep their kids safe?
Dr. Haller, you want to take that one, or you want?
I'm sorry, I didn't quite hear the whole question. I'm sorry.
Oh, no worries. I can reread it. With schools and colleges going back in session, what precautions should parents take to keep their kids safe?
That is a huge question. I will also say that one of the things about this this whole situation, this pandemic, is that there is no one answer. There is no right answer. There is frankly no good answer. I think that in any case of any child, any parent, any teacher, any school system, what we are trying to do is find the least worst solution in a very, very difficult situation. One of the things that, you know, as Dr. Strand was saying, one of the things that's remarkable, and I'd like to hear what Dr. Miller has to say about it more, is that it seems that, you know, the younger kids are not going to be the super spreaders of this. It may have to do, and again, I've been reading some stuff about they may not have the receptors to actually pick up this virus, and so it just sort of slides through them, I guess. I don't know. But anyway, the younger a kid is, the less likely they are to get really sick with it or to bring it home to other people. But as kids get older into the middle school years, and especially as teenagers, then they are more like adults in terms of the importance of wearing masks, good hand hygiene, and consistent physical distancing, especially when inside. The American Academy of Pediatrics did come out with some guidelines, and despite what has been said about them, the American Academy of Pediatrics, while they have, they hope that whenever it's possible, kids can go back to a physical school setting. They by no means said that all children should go back to school. It was not that kind of blanket statement. One of the things that this has brought up, this whole pandemic has brought up with this situation, is the disparities that we see in different school systems. There are some schools that have a lot of physical space inside of their buildings that can allow desks to be spaced 3 to 6 feet apart. There are larger rooms that kids can go in. There are even covered outdoor spaces where kids can congregate more safely than they might otherwise in some school systems and some school districts than others. And unfortunately, those school districts that have less in terms of physical buildings also probably have less in terms of the ability to do the kind of online teaching that might be necessary in the current situation. So that is not really a good answer because there is no good answer. But what I would say is that this is going to be very important to talk to the school system, find out what their plans are. Essentially, what we want with kids who are early school age to middle school and above is that if they are in a classroom, at physical distancing of at least 3 feet. Kids should be wearing masks pretty much all day, especially when they're inside. And teachers, frankly, teachers and adult personnel are the ones who are probably most at risk in schools because they're most at risk of passing it to one another. You know, the creative things that are coming up in terms of having kids go maybe 2 days a week and do electronic other days, changing the start and stop times of classes so that there aren't a lot of kids congregating in the hall at the same time. These are the things that parents need to ask questions about and frankly need to get involved with their school system about.
Thank you, Dr. Haller. Next question that we have is, what are the factors contributing to children being diagnosed positive less than adults?
Ooh, that's a great question. I don't know, Erin, do you want to tackle that one?
One second.
I think I'll just throw in one comment that I think right now, kids under 18 make up about 7 to 8% of all the positive COVID tests nationally, but they also make up a very small percentage of people being tested. And so, you know, it's hard to find places that are going to test asymptomatic kids, and so many of the kids are asymptomatic that getting those tests done is more of a challenge. That doesn't talk at all to why is it that kids are asymptomatic. So I don't know if Erin wants to tackle any of that.
Yeah, it does seem that like Ken was saying, Dr. Haller was saying, the virus seems to not be able to invade the cells of the respiratory tract in the same way that it does adults, and seems to cause less symptomatic disease in children. But there is some percentage of children, and we don't really know how to define this population, that is spreading the virus to other people, but are not sick with the virus at that time. And one question is, how contagious are they? How contagious are they in the school setting? How contagious are they in the home setting? And the preliminary data, as Dr. Haller was saying, particularly for children under 10, is that they are a very small contributor to the overall contagion in the community. One of the unanswered questions is, once we open up schools, or if we open up schools, when all the children are in together in a school setting, as opposed to what has recently occurred is more in the household setting, does that rule still hold true? Does what the preliminary findings of that the under 10-year-old children don't spread the virus well, does that hold true in the school setting? I think is not yet been determined. And so there's, as I think one of the themes of tonight will be that there are so many unanswered questions about COVID-19 that we still need to learn to even answer the basic questions that we're trying to address tonight, like going back to school.
If I could just add one thing, and this is completely anecdotal, but I noticed this and I put it on Facebook, and I had other pediatricians saying, yeah, I noticed that too. Kids have seemed to adapt really well to masks. I mean, we were concerned that it would cause them to touch their face and they wouldn't wear them and they'd be cranky. But I've had kids in the office who are they just love their mask and they love wearing it. And on top of that, what's been really interesting is kids are being like the mask police for their parents. I overheard one kid as I was walking in a room, so this kid was like 7, saying, "Mom, the mask doesn't work if it's under your nose." And it kind of reminds me when I was a kid, because I'm really old, and seatbelts in cars were very new. When we go, "Mom, Dad, aren't you going to put on your seatbelt?" And of course, the next generation, like Dr. Strand and Dr. Miller's generation, say, "Mom, Dad, why are you smoking? That's awful." I mean, kids are actually really, I think that kids might actually be, like a good vector of mask use, just like, other generations were convincing their parents to wear seatbelts and to quit smoking. One of the concerns we had was kids won't wear masks. And I think a lot of adults may have been projecting that because kids are doing better at it. It's completely anecdotal. We should do a study.
No, I think I agree. They're good social motivators for us adults who can't seem to get it together.
If I could expand on that, there's still some unanswered questions about how good all of us are at wearing masks. I know for myself, I tend to have a really itchy nose with all those the surgical masks that have little strands of fabric in there. And I'm constantly, even though I know better, touching my nose, scratching my nose. And if I have trouble doing it, I imagine that there's the 6 and 7-year-old is going to have even more trouble. So it's possible, like Dr. Haller was saying, the kids are very excited about their masks, but maybe we're missing something that we haven't yet picked up on is that these behaviors, like I described, touching your face even when you're wearing a mask, is in the school setting going to transmit much more than we realize. It's just one of those unanswered questions at this point.
And I'm just gonna steal Michelle's role as mediator here and moderator and reflect on one of those questions in the chat room that is still building on that, which is about kids who have sensory issues. I mean, those kids with masks, that is a real challenge. And I think we don't have good answers for how to help those kids and what other kind of innovative designs can we come up with for masks or other, you know, face shields or what have you for kids that have sensory issues. I think that I'll just go ahead and take the punchline that I'm not sure that Dr. Haller, Dr. Miller, or I will have great answers for many of these very specific questions that people are posing in the chat box. We certainly can tell you what we know, but the honest answer is we don't know enough about transmission and pathology of this virus to give you really concrete answers about some of these things. I love that that Dr. Stiffelman is commenting in the chat box that some autistic kids are great with masks because it maybe helps them feel more secure, gives them some coverage or something to get behind. Who knows? I mean, everybody's going to deal with it differently, and we're all going to have skills and challenges with different parts of this. So it'll be interesting to see how this works.
All right, thank you. Our next question is, what role, if any, does the St. Louis County Health Department have in regards to school closures? And if private schools have to follow their guidelines? There's a lot of parents or families joining private schools. Not sure if we'll have that answer, but we can try.
So both the city and the county have guidance, and the health department, I mean, we can all read the paper. There's a lot of debate about who's in charge and who gets to make decisions. I don't know, Dr. Haller, if you have other comments. There's certainly guidance. I think the guidance is out there because it's scientifically grounded and evidence-based as best as we can at this point. But I think that you know, private schools, especially small private schools that are under a certain threshold, can sometimes avoid some of the regulations that the larger or public schools have.
Yeah, as far as the city and the county health departments, I think that they are, you know, I think that as Dr. Strand said, they have some guidelines, but the thing is that individual districts, individual schools are so varied in their resources and their ability to do the kind of physical distancing and mask use and individual attention that kids need, that it's, I would suspect that it would be hard for them to come up with a blanket policy on this, and that it's still going to be up to individual schools to do it. And again, I think that one of the reasons the American Academy of Pediatrics a few weeks ago put out a policy or at least some guidelines on this, what to think about. One of the reasons that they did talk about the need for in-person school attendance when possible is that there are a lot of things that kids are not getting because they're not in school. There are some kids who are not getting food. That is their main source of nutrition. There are other kids who are who get special services because they're special needs kids. There are other kids who, the school may be the place where various types of neglect or abuse are detected. So the thing is that it's the difficulties with learning are bad enough, but the fact that these services are not being provided is also something that we have to think about, because these lead to morbidity and sometimes mortality also. So that's part of the very difficult calculus that's going into all this.
And I think it's also important to recognize that we have seen statewide and nationally a real increase in some behavioral health issues. So depression, anxiety, acting out and oppositional disorders have been aggravated by the quarantine that kids have been living with over the last few months. And even kids who didn't have a history of behavioral health issues have been noting that increase in anxiety or an increase in depression. There certainly has been an increase in suicidal ideation and suicide attempt that we've seen across medical centers across the state. And I think it's really important, whether kids are back in school full-time, part-time, or fully virtual learning, no matter what the next weeks hold for our kids, I think it's really important that we as parents and as pediatricians are very alert to that and spend the time to ask questions and listen and support with a little more patience. I mean, it's hard because we're all kind of at our wits' end with quarantine and being stuck at home with all of our closest loved ones. And I think that we have to dig into our own patience and compassion and listen to our kids and make sure that we are aware of and responding to their needs as best we can.
Thank you. Our next question is, and I've seen multiple questions in regards to this one. I have a 15-year-old with HLHS, seizure disorder, immune compromised, asthma, liver failure, severe osteoporosis. We're currently inpatient. My question is about siblings in school. Our school, as of now, are not taking many precautions. Masks aren't mandatory, no health screenings, limited 3 feet social distancing. I already have a plan to do virtual school with this child, but what do I do with the other sibling who's in middle school?
Great question.
Yeah. I don't know that I necessarily have a great answer for that. I think that the school that the other child is going to, well, the thing is, whatever the regulation, if this child does go to physical school, whatever the regulations are, it's going to be important for that child to wear their mask, to do all the things that we know we're supposed to do, and when they come home, really to again wash their hands very thoroughly, probably change their clothes. Do the kind of things that a lot of us, frankly, who are in medicine, who go home to families, have had to do. Just change out of the clothes you have that day, wash really good, and if that child has any symptoms, they need to stay away from the child who is being homeschooled. Dr. Miller, I don't know if you have any other suggestions on that, but that would be probably the least restrictive I would be, and that's still pretty restrictive.
Yeah, I think there's multiple, I mean, it's a very difficult question, and I think no matter who you are, that's going to be a challenging decision for that parent to make for the whole family, because it has effects on not only the middle schooler who's going to school, but of course the health effects on the child that has multiple medical illnesses. But things to think about, or the way that I would approach it for my own family and what I would recommend is the trajectory of viral cases in the community, I think, is important. If we're seeing cases rising rapidly, I would be a lot more concerned about sending my child to school, regardless of whether I had at-risk medical child at home. If cases are being under control, that would make me more comfortable. Another factor is the school itself. I mean, a parent who has a very good relationship with the school, they feel comfortable with what the school is doing to protect their child, that the teacher of that child is very involved about kind of enforcing rules and masks and social distancing. That would make a huge difference to me if I felt that there was very relaxed rules there. And then, like you said, if there's someone that's at home that has multiple medical problems, it certainly would play a big role in how I would approach sending other children to school. And the other factor is each child, based on their age and their maturity, is going to be different in how much they really would benefit from the in-person instruction versus at home. I mean, there's some children that really would do beautifully in terms of having a parent kind of just supervise them as they work online virtually, where other children would really suffer from not having that socialization. So I think all those things have to be taken into consideration to make that ultimate decision. And it's really a kind of ultimately a personal decision that the family has to make themselves.
Great, thank you. The next question is, my child is a cancer survivor. What extra steps do we need to take to keep him safe?
So I think you're going to hear a lot of the same things. You know, what keeps a kid who's medically complex safe is the same thing that keeps a kid who's a cancer survivor safe, which is the same thing that keeps you and me safe every day. And it comes down to how much risk of exposure are you willing to tolerate. If you're really not willing to tolerate risk and you want zero risk of exposure, then you're going to stay home. And you're not going to have people over, and you're going to isolate. Certainly to minimize the risk while still being able to go out and do everyday kinds of things, you're going to maintain a 6-foot social distance, physical distance. You're going to wear a mask, you're going to wear it appropriately. You're going to have excellent hand hygiene. You're going to keep hand sanitizer in your car, in your pocket, in your backpack. You're going to use it regularly. You're going to not touch your face. And if you can maintain all of those things, then you minimize your risk of getting this disease. And if you don't get the disease, then you don't transmit the disease to either your family, your medically complex sibling, your grandmother who you might go see on the weekend. I think that those same practices are what we know keeps people safe and minimizes that risk. The more risk you can tolerate, the more risk you're willing to take, the more you're going to be free of those restrictions. You know, I have a 20-year-old who fits into that high risk transmission pattern because, you know, if I am very risk averse, then I don't let him go out with his friends. Or I am sure that he understands that he has to wear his mask and he has to wash his hands and he's going to change his clothes when he gets home from being with friends. And not only that, his friends are going to wear their mask. And so it's how much control do I have? How much control do I need to have? How much risk am I willing to tolerate? That will really determine how I parent him.
If I could just add that while it's completely understandable that any parent that has a child that's a cancer survivor would be extra cautious about COVID-19 in that child, that's completely understandable. But it's not all that clear actually that how much additional risk that child is in of severe COVID-19 disease. It may be that the risk is actually very minuscule above a child that's not a cancer survivor. There are some preliminary data from China and then from Europe and then from, not even from the New York and the East Coast yet, but suggesting that chronic lung disease seems to be one of the highest risk factors for severe COVID. Morbid obesity seems to be a risk factor. Diabetes seems to be a risk factor. We assume that the immunocompromised patients who have neutropenia or had a bone marrow transplant are of higher risk, and I think they are to some degree, but we really don't know how much that is. And down the road, we might be able to have a better sense of how worried that parents should be for their child that had cancer in the past, but may not be immunocompromised at the moment.
Okay, thank you. Our next question is, what should a school do when a child tests positive in a classroom?
Well, I think the party line is that a child who is symptomatic in class gets isolated and sent home relatively quickly, and then evaluated for COVID, tested, or seen by a healthcare provider. I think that if someone is positive, if you find out that someone who was in the class yesterday went home, didn't feel well, got tested, and now is positive, then that gets into the whole contact tracing, and there needs to be a deep clean of that room and everywhere that that child was. And each school is going to have to figure out what contact tracing looks like for them and what precautions they're going to take. If they're going to shut that room down for the next number of days and let people develop symptoms, if they're going to develop symptoms, how, you know, that all gets played out is going to be very school system dependent. Do you, Dr. Miller or Haller, do you know if I haven't seen guidance from any of the school systems or from the health departments on what to do with that. It might have come out recently.
What I'm not familiar with a particular policy that's come out. Maybe Dr. Haller is.
No, I don't know that there is one.
Yeah, I don't know that there is one either. And I think that, you know, as you said, Dr. Strand, I think that what probably would happen is that all the kids in that class, those families would have to be contacted. And I imagine what would happen at that point would be that those kids would have to do distance learning for a week, 2 weeks, whatever the current recommendation is, and likely be tested as well as family members, and which is all unfortunate. I would say one of the things the American Academy of Pediatrics is recommending, not just screening kids when they come to school every day, but, you know, because that can be really, really burdensome if you have a couple of hundred kids coming in, but working with parents to do screening at home, like taking your child's temperature before they head to school, and asking those questions. You know, frankly, Dr. Miller, Dr. Strand, and I, whenever we come into Cardinal Glennon, we're asked, have you had a cough? Have you had any diarrhea? Have you had this? Have you had that? So we have to, you know, say no, and we get our temperature taken. We're able to do that at home also, and that just makes it a little bit easier. So I think there is going to be a burden on parents here to do, you know, to really look for symptoms, and at the slightest possibility of symptoms, not let their kid go to school. But I don't think that everything's been worked out. And I will say, not just for myself, but I'm sure Dr. Strand, Dr. Miller, and other colleagues of ours who are on this call, one of the most frustrating things for us as doctors is to say, I don't know. I mean, we like to be here to say, yes, we do know, and here's here's the best thing to do. And right now there is frankly a lot of I don't know that we have to say, to be honest, and just use the best, you know, the best guess we've got. And right now I'd say that's probably as good as we've got.
One of the, normally to answer this question about a positive child in the school, in the classroom, should you shut it down? The first thing I would think is, well, if it's an older child in the older classroom where there's teenagers, they're going to be disciplined enough and understand enough that they're going to be extra careful over that period. They're going to be more likely to wear masks and keep them on, better about hand hygiene. But one of the paradoxes about COVID-19 is that the older children, although they presumably are going to be better in the classroom at, you know, not touching their face and washing their hands than a 6-year-old, but it's the 6-year-olds that are less likely to transmit, and the teenagers that are more likely to transmit according to the data. So that's a paradox that I don't quite know how to reconcile for this situation about what to recommend about closing down the classroom.
All right, thank you. Our next question is, what about those individuals who need to read lips, have hearing problems, etc., or just have a fear of seeing those masks?
Yeah, this is a huge, I mean, I don't know if you all in the community have met this challenge as well, but I had no idea how much I used lip reading when talking to people. I think we all do it and we don't even know it. And my mother-in-law, who is hard of hearing, oh my goodness, it's a lost cause to try to talk to her with a mask on. And I think we all struggle with that. I think that if, you know, the opportunities, technology helps us in a lot of ways. And one of those ways may be to be able to do some learning through technology like a computer, like Zoom, where you can see someone's face and read lips. I think that masks are hard for little kids if they find it scary. And I wish that I had a good solution. I think masks are going to be with us for a long time. I think we have a future with masks for the time to come. And so finding ones that kids find comfortable, finding ones that kids find fun and playful is really important to compliance in the younger set and to making sure that they're comfortable through this. It gets back to the kids with sensory issues and tactile issues. How do we help them manage through this in a way where they can become comfortable with masks?
Yeah, there are, I know I'm seeing a lot more availability of masks that have a little plastic window here so you can see the mouth. They're otherwise cloth. And of course, that little plastic window is impermeable to viruses or to anything, to any air, but there's still cloth around it. So it's probably at least as effective as any cloth mask, but there's a lot more availability of that. And, some people are making them and putting that out there in social media to get them, or I'm sure you can Google it, face masks with plastic window, and find some in your area. But I would agree with Dr. Strand. These masks are here to stay for the foreseeable future. And that's probably one of the best adaptations that I've seen for that.
All right, thank you. Next question. Would you send your children to school? If so, why or why not? Does your answer vary based on the age of your child, since you mentioned the younger kids seem to be doing well with the virus?
I
don't have kids. I'll let those two answer.
Well, I've already outed myself that I have 4 kids, and they range from 7th, well, now 8th grade coming up to junior in college. And they are all going to go back to school as they're able to go. And that is based on a very honest discussion with them about the risks of going back to school. My youngest has anxiety, and we've had a lot of long conversations about this and the benefits of being in school and having a routine and not being stuck in front of a screen 24 hours a day to do school, and being in person, or even if it's a couple days a week. But how do we mitigate that anxiety and help him to feel like he's in control of his environment? I think that it does. Each child has had a discussion in a different way with me about going back to school with COVID and how they're going to deal with it, because they are so widely varied. I think that's the beauty and the challenge of parenting, is talking about each one individually and finding the right answers. Part of our sacrifice is we are trying to shut down outside of our quarantine of the strands. We're trying to keep to ourselves and not put ourselves at excess risk outside of the work that my husband and I go to do. And then when the kids go to school, we're going to have to be very mindful about that as well. And I'm not going to be surprised when someone comes home from school and says, there was a COVID positive kid at school, and by the way, I have a cough, and we are going to get screened. I think that going to school I'm accepting that as a possibility as we move forward.
I'll just comment. I have 2 children, 13 and 9, and just to describe the conversation that my wife and I had about this exact question, one of the major factors was that our youngest one is the type that really would struggle at home to, without the motivation of being around the other kids and the socialization and the routine of going to school. He would struggle much more than our older child, who really is much more mature and able to be self-directed, have self-directed learning. And so that did play a big role. However, if, like I said before, if the trajectory of viral cases in the community was going up rapidly, and I thought that the risk was high that there would be spread at school, that would obviously play a role. And another thing that would play a role is we're lucky enough that we don't have anyone at home that's immunocompromised or has chronic lung disease. But if we did, I'm sure that that would factor in very clearly into our decision-making. So I think the answer to the question is yes, I would send my children to school, but it's with all those caveats of our particular situation.
And I want to be clear that there is not a wrong answer here. You know, different families are going to say, we are not sending our kids to school. We're not doing it this year. We're going to do virtual learning for at least the first semester. That's a totally fine answer. There is no imperative by anyone that someone should assume more risk than they're comfortable taking. I see a lot going on in the chat about residential colleges, and you know, like I said, my oldest is a junior in college this year, and he is planning to go back to college. And I will say each college has their own mitigation plan, and you need to be very engaged with that college and figure out exactly what the mitigation plan is and who and how those kids that are going to get COVID, because every residential college is going to get COVID, how they're going to be treated, what the expectation is. If you're going to have to fly a kid home or drive somewhere and pick them up, I mean, you just need to know that at the front end so that you can set expectations appropriately.
All right, thank you. Our next question is the 3-foot distance safe enough?
I can comment a little bit about that.
Please, Erin.
The science behind the 3-foot rule is really something that I think is going to change, and is a little bit arbitrary that we're using such 1 meter, 2 meter rules. One of the concrete pieces of data that has come out is that if someone is talking without a mask on, the respiratory jet of this virus in one study showed that it could go out to 8 feet. But if they had a surgical mask on, that was limited to 8 inches. And everywhere between 8 inches and 8 feet was about like a cloth mask, a bandana, something that's less covering of the face, so or a single layer of cloth. All of those things allow the virus to be spread on a further distance. And so to answer the question about is 3 feet safe enough, it definitely would depend on what mask that person is wearing. And also there's just unanswered questions about the ability of the virus to transmit itself in an airborne fashion. So the way that I think about airborne transmission is that these are very small particles that a person just breathing would put into the air. And the classic examples would be measles or tuberculosis, where these tiny particles of respiratory particles that are less than 5 microns and have the ability just to kind of, you walk into a room and they are suspended in the air for hours, so that even after that person leaves and someone else walks in an hour later, those respiratory particles are still there. That's what TB and measles can do. What has been debated kind of endlessly in the infectious disease community is this truly, does COVID-19 really act like that? My personal feeling is that if you remember the Diamond Princess cruise, I believe it was called, that was one of the original data that we had about transmission. And they found on that cruise ship that for each person that was infected, they infected 2.2 additional people. And if you compare that to measles, with each person with measles, they infect around 18 people. I don't think measles and COVID-19 are the same, but the question is, can it transmit by airborne some of the time, or maybe just occasionally? And that's the question that we really don't have a firm answer to. And if it does occur occasionally, but not all the time, do we need to treat it like it occurs all the time? I think that really has a huge impact on how we would think about children going to school, or taking off a mask for a moment, or hospital settings where they're immunocompromised patients. So there's so much to learn about that I don't think the 3-foot rule, I just think it's oversimplified at the moment.
All right, thank you, Dr. Miller. Next question is, if COVID enters your family unit, what steps or protocol needs to be put in place at home to protect those who aren't positive?
Well, that's going to depend on who is positive, because if it's a 5-year-old, it's hard to have them quarantined by themselves. If it's an 18-year-old, you might be able to get some distance and separation to minimize the exposure. I think all of those same rules are in play. If somebody's positive, you need to think about who else is in the household. If there's somebody who is at risk or high risk, then they need to be isolated away from whoever is positive. I think the masking at home and physical distancing as much as possible with extraordinary hand hygiene. If somebody's positive, we know that during eating and drinking, when someone has their mask off, that transmission is more possible. And so you need to be very cognizant of those high risk times. I don't know if Dr. Miller or Dr. Haller have other comments about that.
I mean, I think that's pretty much the situation. Again, if it is a 5-year-old, that's going to be difficult for them to, keep them in one room because 5-year-olds just want to be everywhere. I would also assume that if you have a 5-year-old in the house and that child turns up positive, I would just assume that the entire family is positive, and probably the entire family would need to quarantine for the amount of time that's currently recommended. However, if it is someone of a different age, then they can go to their room. And, there are a lot of 18-year-olds who would love to spend a lot more time alone in the room.
Yeah, I have to pay my 18-year-old to come out of his room, so.
Yeah. Again, not to make light of it, but it is very dependent on the age of the person. And so I would agree with what Dr. Strand said.
Oh, you're muted, Michelle.
Sorry. Thank you.
It's great we made it this long before any of us did that. That's
I know. I've been trying to do it on the backside. Our next question is, my children's school won't require a mask and is unable to physically distance the students and the staff. They're instead going to attempt to utilize cohorts at the secondary level. How effective do you see this being, especially since they cannot be maintained for busing or sports?
What does that mean, that the cohorting at the secondary level? I'm not.
Like secondary school level, like 5th, 6th, 7th, 8th grade?
Oh, I see.
Also, there are some schools who are trying to do A and B days, and so half the students will go on A days and half the students will go on B days.
Right, and in other schools, if kids are taking, if they're say in 7th grade and they're taking biology and algebra and something else, then they might stay in the same classroom and have the teachers change rather than going out into the hall. So that's the kind of cohorting that I've been hearing about.
I don't have the data. I don't know, Aaron, if you have the data, but I think if you're cohorting, but then you're mixing on buses and at sports and at lunchtime, then you're not cohorting.
Yeah, and also the children, if I understand correctly, they're cohorting during the day, but they're going home to their families at night, and presumably maybe involved in other activities after school, which are not the same cohort of their classroom. So, my first glance at that, it doesn't quite make sense as the best option, the safest option.
Okay, thank you. Our next question is, what would a safe preschool classroom look like, or what kind of things need to be removed from the classroom?
I think that's a great question. I think that anything that's in a preschool classroom has to be able to be wiped down with some sort of sanitizing wipe on a routine basis. I'm not sure that preschoolers share body fluids so frequently, spit and cry and sweat and tears and everything. I think that again, it's hard to know, since little kids don't test positive very often, what the true risk really is. Aaron, you want to talk about that at all?
Well, this is one thing that I haven't seen data on. Maybe some of people in the audience have, but ever since the pandemic began, although it's been summer and there hasn't been school, there's been daycares open for the last 4 months. And so my understanding is that the preschools and daycares that have been open since the pandemic began have not been a major source of transmission from child to child. Maybe from adult to child on occasion, but the child to child transmission, even though you would think there would be ample opportunity for it, just has not, to my knowledge, been seen. Now, maybe there's a more detailed study that's going to come out that shows that more transmission occurs than we think. But from what I've heard so far, it's a minor source of transmission. And I think that's one of the unanswered questions of COVID-19, why that is.
Yeah, and it does seem that probably the people who are most at risk in a pre-K setting would be the teachers in that setting with each other. Still, in that setting, trying to cohort groups as much as possible, utilizing outdoor spaces where possible. Again, as I mentioned this earlier about kids and masks, kids really are good at games and conforming, and if you have hand washing games and wearing our mask games and don't touch our face games and things like that, trying to teach them that as much as possible, limiting unnecessary visitors to the building, so forth. But like Dr. Miller said, it has been interesting that we really haven't heard of daycares being the source of outbreaks, which is, I think, we'll have to keep studying that.
Yeah, all of the data that gets published on a weekly or every 2-week basis by age group lumps everybody as an under 10 group. And so it's really hard from the data that's readily available to pick out that very young age group to see how they're impacted.
Mm-hmm.
Okay, so Michelle is frozen. She's hopping back on. So I'm going to read one of the questions on here. As I start getting requests to write exemptions for mask wearing for kids, what sort of things, if any, would prompt writing such a note?
I will say none. I mean, I honestly can't think of anything other than, again, extreme sensory issues. But from a respiratory standpoint, there really is no reason for a mask exemption for a child.
Okay, next question. If college kids who live away from home become COVID positive, should they quarantine at school or be sent home to quarantine? And that was actually, there were a few questions surrounding that.
Yeah, I saw those. Most of the school plans that I have seen from colleges have a place for quarantining kids on campus. I think that I can't imagine a residential college that wouldn't need to have that because if somebody has to get on a plane to get home to quarantine, that makes no sense at all. I know that, again, my son's school has dedicated an entire dorm to their COVID positive kids that are going to be on campus, so that if somebody tests positive, the kid moves into that dorm for 2 weeks and they have medical care available if needed. I think that, for non-residential colleges or commuter colleges, they are going to have the same issues with travel that high schoolers and middle schoolers are going to have this fall. But I think that residential colleges that don't have a place to quarantine on campus aren't thinking through this process very well.
Okay, so next question. This is an interesting one. If no vaccine is ever successful, Dr. Miller, how long would you expect this COVID virus to stay in our communities and therefore cause all of these restrictions? Meaning, do you foresee years of this?
I was so glad you got to this question because I saw it in the chat box and I wanted to hear Aaron's answer.
Well, I would say that is the $1 million question. I mean, really, that the answer to that question really changes the future of our economy and our educational system and our socialization. And all I know is some theories by some experts in the field about that question. So there's really not, it's not known, if there's no vaccine, and whenever someone gets COVID-19, they have permanent and 100% immunity, that would be very different than if there's no vaccine and someone gets COVID-19 and they have 3 months of immunity. And so the early data is suggesting that when someone gets COVID-19, they may be protected for some period of time of months, but maybe not years. And that hasn't, we really haven't had enough time to study that thoroughly yet. But if it's true that the preliminary data is that it only lasts 3 months, that doesn't bode well that it's going to, we're going to have a resolution. What we might see is a seasonality to COVID-19 where we see more spread in the winter and minimal spread in the summer. But even so far, I mean, we're seeing an uptick around the United States, even in areas that have very hot climates right now. I mean, St. Louis is going up, it's slow, but Florida is going up at a rapid pace. So it's hard for me to say that it's going to become seasonal to a large degree. But yeah, I don't, without the vaccine, I kind of doubt that we're going to see a major change simply because I don't think there's going to be long lasting immunity. And I'm kind of skeptical that we'll have a therapeutic anytime soon that is very good. I mean, if you can think about like oseltamivir or Tamiflu, it's the best we have against influenza, and it's not particularly good. So if we have something as good as Tamiflu, that would be good, but it would be quite disappointing if that's the best we can do.
All right, thank you, Dr. Miller. Next question, and this will probably be our last question as we wrap up this evening. Do you think public playgrounds should reopen? Many in the county have been closed for months. Do you think closing outdoor playground equipment is necessary to prevent the spread of the virus?
That's for you, Dr. Miller.
Well, I mean, it's interesting that when I think of a playground and all of the surfaces, I think of kind of those preschool classrooms that we were talking about. It seems like a great opportunity for kids less than 10 to touch other kids' secretions, saliva, things like that. Probably not the same degree as a preschool classroom, but it might approximate it. And so I think if the rate of spread is insignificant and we can show that with data, then I think it'd be great to be able to open that up and then have some type of system in place where people can wash their hands and they give sanitizer for free, that there's not any lack of sanitizer. That might be doable. But if the data is not clear, or the data shows that it is a source of spread, then definitely wouldn't be a good idea. So I think that I don't really have an answer. Long story short, I don't have an answer.
Yeah, I would agree. It does seem that if these playgrounds would have hand sanitizer stations, and we could teach our kids that when you go down the slide, when you come off, you use the hand sanitizer. And then when you get on the swing and you come off, you use the hand sanitizer and don't touch your face. That may be really helpful, because outdoors is one of the best places you can be. It does tend to disperse whatever's coming out of, whatever aerosol is coming out of our mouth, and make it much less likely that we're going to infect one another. So I think it requires more study, but I think it's time to explore that again.
All right, thank you all. As we wrap up this evening, I'm going to ask each panelist if they have some final thoughts that they want to leave the group with.
Well, my final thought would be that COVID is around for some weeks and months and undetermined time to come. And what we as a community can do to really help with COVID in our community is to be mindful of risk for other people, and to help to mitigate other illness and infection that competes or coincides with COVID. So getting your flu vaccine, seeing your primary care provider for preventive healthcare. Those are all really important right now, and probably all the more so as COVID is in the community. So let's mitigate the risk of the other diseases as best we can.
Right, and as the primary care provider on the panel, I would echo that. There are a lot of really bad diseases we can prevent, and the last thing that we need is for some kid to get whooping cough and then get COVID on top of it. That would seem to be a recipe for disaster. I would also say that this whole discussion around school and kids and so forth has brought up, and I referred to this a little bit earlier, the fact that schools and education in our society have been chronically underfunded and under-resourced. And I think that this is an opportunity for us as a society to look at that in the short term, as Congress is considering bills for relief of various sorts, making sure that education funding, especially as kids are starting to go back to school, to get them the resources they can get so that whoever can go to school can, and whoever, doesn't feel safe there will be able to get things electronically is important. But long-term, looking at how we are educating our kids, that's really going to be paramount, and that would be a project that I think we can all agree on.
Yeah, so my final thought would, the traditional approach that public health authorities have taken to how we would approach a pandemic is that we would have identification of the people that have the disease through testing, contact tracing, isolating those people, developing a vaccine that's effective. And so I think my optimism is that I do believe that we will have a vaccine that is quite effective. It may take time. I don't know if it's going to be in the next 12 months that we really have that, or the 24 months, but I believe that through all of the new techniques that are going into it, the mRNA vaccines, we're taking a whole new approach. I do believe we'll have something that is effective. But I think where my pessimism is the traditional approaches of testing, contact tracing, isolating, and in this case, wearing masks. We're seeing either governmental pushback on those or societal pushback on those, where there's pushback about wearing masks or not allocating enough money for contact tracing or not having enough testing. Those are my biggest concerns, because I don't think we can do the core techniques of pandemic control without lots of test availability and people with the manpower to do contact tracing in each community. So I think that's our job, is to communicate that, as for healthcare providers to communicate that, the importance of allocating the money for that. I think it will be money well spent, just like the vaccine money, I think will be well spent.
Okay, before we close, Michelle, Molly put the locations for testing in the chat. And I just want to encourage everyone that those places are, there's a county one and a city, there's a county website and a city website where you can see where you can get testing in the community. And I would encourage everyone to utilize those spaces if they need to get testing. You should call to make sure, if you have an asymptomatic person, that they will test someone who's asymptomatic. But let me just reinforce that the emergency rooms are not the places for children to come to get tested for COVID. Emergency rooms are more expensive if you just are coming for a test, and it takes up resources that kids need for emergency care. So please utilize those resources for community-based testing.
Thank you. I was going to mention that as well. We also have recorded this session tonight, and we're going to be posting it to our social media sites, so that way you can have this for future reference. But again, thank you all for joining our program. Please remember to visit our website, www.cardinalglennon.com, for further information and on access to our care at Cardinal Glennon. And I again want to thank our three panelists, Dr. Strand, Dr. Miller, and Dr. Haller, for your time this evening. Thank you all.
Thank you.